Good evening, everyone, and welcome to the Association of Minority PAs third annual fall webinar. My name is Dr. Khalida Denoof, and I'll serve as the treasurer of the association as well as a member of the education committee. We're so glad that you have joined us for an evening of learning, conversation, and professional growth. This evening, we have two wonderful speakers here for you today. Our first speaker is Dr. Tajuana Lordeus, who will be presenting an update on suicide awareness. Dr. Lordeus has over 2 decades of experience as a PEA, a doctorate of medical science degree, and extensive leadership and authorship in psychiatry and mental health. Dr. Lordeus has been a physician assistant for 23 years, practicing across various areas of medicine, including psychiatry and most recently as a clinical advisor for Optimum. She has served as a psychiatric care with Mind Behavioral Health Clinic in Raleigh, North Carolina. And in 2022, she earned her doctoral degree from Rocky Mountain University of Health Professions. She subsequently earned her Certificate of Added Qualifications, or her CAQ, in psychiatry, and has been a published author with works including The Little Brown Boy Premiere and The Little Brown Boy Goes to Chicago. Dr. Lordeus has facilitated mental health summits and presented at many professional conferences, including the North Carolina Academy of PAs, Winter Conference and Summer Conference, as well as the South Dakota Academy of PAs annual CME conference and PA Women in Philanthropy. In addition to her clinical and academic work, Dr. Lordeus lectures widely on mental health and serves on several boards, including Lawrence Technological University PA program and the NCCPA Health Foundation, the Association of PAs in Psychiatry, and Tri-Unity Medical Clinic. If you will all please offer a warm welcome to Dr. Lordeus as she presents on suicide updates.
Good evening, everyone. Thank you for the invitation to be here tonight. I'm glad to see the cozy group in attendance. And I was telling one of the people who opened up the meeting tonight that I just attended Psych Congress and I learned so much information and I want to share all of it with you, but that's not possible in 30 minutes. And so I thought about making our presentation tonight a little cozier, but I am going to give you some information that I hope you'll find valuable. But at the end, I want you to prepare yourself to do a little sharing at the end. So I wanted to share that I am not being paid a ton of money to be here tonight. I have no financial disclosures, but I'm excited to have an opportunity to speak to a group of my peers. And anytime I have to present, I always look at it as an opportunity for me to grow and learn. You know, oftentimes these introductions present you in the light of being an expert, but I actually learn so much when I have to prepare a lecture to present to other people. So I'm thankful for this opportunity because I did learn some new things as I was preparing this lecture for you tonight. Oh, before I meant to also add that I have a couple of images that were generated through AI, but all of the ideas and other content, I have cited references for them, or they're my original ideas. They are not representative of my employer. And I had one other thing to share, but it'll come back to me in a moment. The disclaimer is that you may want to step away if you need to address any personal needs. Sometimes the content can be a little difficult to digest, and I've provided resources available for any emotional distress. NAMI Helpline is open from Monday through Friday from 10 a.m. to 10 p.m. And these resources you might want to share in case you're not already using them for your patients. And 988, of course, a lot of people know about that already, but just to know it's open 24/7 for call, texting, and chatting if you need some extra assistance. The objectives for tonight, first of all, I'd like to review the definition of suicide and provide some epidemiological data about suicide prevalence. And then if we have enough time, I have a few situations that impacted me deeply that I'm willing to share tonight. I'll also discuss some unique risk factors for minority clinicians, and I'll get you guys to help me with that part. And then we'll sip some tea together and have a moment to engage at the end. And so I was excited to see Kimberly wearing the similar color I'm wearing tonight because September is Suicide Prevention Month. And as you can see on the ribbon, purple is on there as well as teal. I did do some research before our talk this evening to try to find some information about what the colors represent. Some resources say the teal represents PTSD and the anxiety component that may be present, and the purple represents suicide awareness and prevention. The National Alliance on Mental Illness usually has an awesome toolkit with some media resources that I love. Normally, if I weren't so busy, I'd have all my social media platforms blasted with this type of information. They have images that you can put on your background and on your social media platforms that raise awareness without you having to actively create a lot of new content. So first, we'll start with some definitions that I obtained from the Dictionary of Psychology, the APA Dictionary of Psychology. So suicidal ideation, that kind of means thoughts about ending one's own life. And most of these occurrences do not culminate with suicide. Sometimes clinicians, and when we're talking with those who are experiencing emotional distress, we may not want to ask about suicidal ideation because we're afraid that that might lead to an action being taken at some point. But I'm going to share another slide in a minute that gives you a little bit of comfort about talking about suicidal ideation. And then suicide is the action of ending one's own life. So about 5% of adults have suicidal thoughts, and it's very similar between blacks and whites, and almost twice as high in multiracial adults. And I said about 5% of adults because I'm going to be transparent and let you guys know that at certain times in my life, I personally have had some suicidal thoughts. They were just fleeting thoughts in the moment of distress, but it was comforting to read that it's not a very, very, very uncommon circumstance to have suicidal thoughts. About 5% of adults do have those thoughts within a year. And that equates in a year's time to about 13 million people thinking of what it would be like if they were no longer here. 2.4 million adults in a year had thoughts and made a plan, an actual plan to end their life by suicide. That number whittles on down to only 1.2 million adults had serious thoughts of suicide and actually took an action towards ending their life by suicide. Now, I said that number whittled on down because any person who dies by suicide, it's a great loss and a travesty. But we went from about 13 million down to 1.2 million who actually took an action towards ending their life in 2022. And this number actually increased to 1.5 million in 2023, depending on the references that you seek out. And interestingly, as I was doing the research, I couldn't get the graphic to translate over, but the behavior surrounding suicide is very, very variable. It can range from having serious thoughts to making a plan to end your life and taking action with a plan to simply taking an action without previous serious thoughts of suicide and a whole bunch of different combinations that are not the typical combination you would think that ends in suicide. Some people don't plan to end their life. They just have a spontaneous action that they take. Other people may make a plan but never share or don't even have serious thoughts about it. So please also be aware that there is no complete count of suicide attempts in the United States because of recording and a lot of stigma surrounding that topic. Accurate accounting for that is not available. So here's some general population statistics based on 2023. I referenced the American Foundation for Suicide Prevention, as well as Coming Together to Prevent Suicide in Black Communities resources. Suicide is the 11th leading cause of death. Men die by suicide 4 times more than women. And about 50% of suicide deaths were through the use of firearms. Oftentimes, you'll hear advertising about safety where firearms are concerned, because half of suicides are done through the use of firearms. And it all surrounds the access to lethal means portion of when that idea comes for ending your life and actually being able to grab something to carry it out. And then some recent data showed that suicide increased slightly for ages 35 to 44 years of age and 55 to 64 years of age, but it decreased for other age groups. And suicide rates were the highest in age 85, the second highest was in age 75, and whites had the highest adjusted suicide rates in the United States. But between 2009 and 2019, the suicide rates increased for more than 50% of our Black youth between the ages of 5 and 11, and for older adolescents between the ages of 10 and 19, the rates were even higher. And I like learning these different statistics. They don't stay in my mind, so it's kind of good for me to get a review when I have to present. But another stat to share is that one person completes a death by suicide every 11 minutes in the United States. The World Health Organization shares that someone dies by suicide every 40 seconds. So that is such a travesty that so many lives are being lost by suicide. I found this article titled Acknowledging Suicidal Ideation, Depression, and Anxiety in Physician Assistants. A survey was done on 728 physician assistants and 322 PA students between November 2020 and February 2021, with 57.9% of those surveys returned. And the questions were from the PHQ-9 and the GAD-7, but they also peppered it with some additional questions like, have you ever felt suicidal or attempted suicide since the start of your professional career? And on that study, it showed that most PAs and PA students did not have thoughts of self-harm or suicide. PA students had higher likelihood of suicidal thoughts, and of those that did have suicidal thoughts or tried to intentionally end their own life, the stressors that caused those thoughts were from work or from school. And unfortunately, I'm happy that we're having this time to share and talk about this topic, because 1/3 of those students and PAs did not share with anyone that they were struggling with those thoughts. Students did seek out help at higher rates than practicing PAs in this study. So, of course, burnout, we see it everywhere. It's talked about everywhere. I've seen it on my different social media platforms. I've had people reach out to me talking about burnout. So I'm going to just share that 1/3 to 1/2 of PAs express symptoms of burnout. And suicidal ideation has been linked to burnout and recent medical errors. I'm going to ask if it's possible for one of you guys to come off of mute and share with me what symptoms of burnout you think that might look like. Well, oh, I see one person. Thank you, Kimberly. Can you
Yes.
explain to us what some of the symptoms of burnout might look like?
So one of the things that pop in my mind immediately would be difficulty concentrating. I think
Yeah.
when you even get on like the severe end of burnout as a practitioner, you get to a point where you don't really care what you're
Hmm.
doing when you're taking care of patients, which is when it becomes far more severe and dangerous to you and the patient. So those are kind of the two things that pop into my mind.
Thank you very much. You're right on point. Shaney, you can share as well.
I was just going to say that something that has been a factor of myself knowing that I'm kind of in the burnout phase is sometimes an increase in frustration.
Mhm.
Like little things throughout the day are just really frustrating, and it's kind of hard, to move past them. And sometimes you can take it home and be even more frustrated at home as well.
That's right.
That's how I know that I'm a little bit burnt out.
Hmm. Well, thank you, ladies, both for sharing. And you're right, both right on point because it can extrapolate out to your relationships. It's not only symptoms that you may experience at work. However, burnout can be attributed to, the stress that you experience at work. But some other symptoms that was not mentioned possibly, but I know that you ladies are aware of them. But for our purposes of learning together, are feelings of overwhelm, fatigue, that compassion fatigue that we were kind of touching on, having that lack of motivation, having that cynicism. We touched on that a little bit as well, where you kind of step away and you're not as empathetic as you could be. But sometimes people also develop somatic symptoms like headaches, muscle aches, GI symptoms of nausea, vomiting, or diarrhea, mood changes, detachment, where they just, kind of step away and don't really care, and then have that lack of empathy. So when I was doing the research for our talk today, I kept seeing that there's not a lot of data regarding physician assistants and suicide. So we often will glean our data for our purposes from the studies that have been done on physicians. And I'll infuse some of that work into the talk tonight. But suicidal ideation is more commonly reported by physicians compared to workers in other fields, according to an article that I read titled "What Every PA Should Know About Mental Illness and Suicidal Ideation." And there's a lot of different reasons for why that happens, but in general, the risk for suicide for healthcare workers is quite high. There's a disproportionate risk of suicide. Physicians are at increased risk for suicide, as I mentioned, and females have a higher risk than other healthcare workers. And this can be extrapolated to PAs too. Female clinicians have some unique struggles that make them at higher risk. And so I'll stop chatting to get a little bit more sharing because the next thing I'm going to share with you is something that I learned when I reviewed the salary report for 2024 that NCCPA put out. And it was interesting to see that 71.6% of PAs are women, according to the resources from NCCPA. So I'm going to ask you guys to share why female clinicians have some of those unique struggles and make them at a higher risk for suicide as a healthcare worker.
So one thing I'll say is the attendees are not able to come on camera and come
Oh,
on
okay.
mic.
Okay.
I
Thank you
will
for
be one of the
sharing that.
participants. um, so I think a part when it comes to women facing these issues, the first thing that kind of pops into my mind is just the additional work that women face. So just outside of having to do your job as a PA, often women have additional work outside of that. So
Mhm.
whole life, whether they're a mom or just taking care of their home or their other family members, parents, whatever it may be. And I think that just adds some additional stress to them, maybe moving them more in that direction at a risk of suicide.
Thank you, Kimberly, my wonderful participant. I appreciate you. And you're absolutely right. And depending on what culture you're from, sometimes you don't get any allowances for the 40-hour work week, in addition to all of those things. Some other things that I read as well is there may be a reluctance among women to seek out extra helps because they don't want to have people view them a certain way for accessing those certain helps. And then, of course, there's always mentorship and things like that that can interfere with you feeling well in your workspace. But some other circumstances that can create a risk of suicide are having the challenging work conditions, the variable work hours that many of our occupations require. Sometimes we have to do shift work. Sometimes we experience emotional distress from dealing with difficult patients and their families. We often have exposure to disease, job hazards, and workplace violence, and exposure to human suffering and death. And of course, as medical providers, many times we have access to lethal means, such as medications, and we know which ones will work a certain way that can end our lives. And this was the race and ethnicity of PAs by race. That was from the NCCPA statistical profile. And as you can see, minority PAs are those little tiny numbers down below the 79.4%. So Black and African Americans make up 3.4% of PAs, and then it goes down the line and gets smaller. So minorities can often have some unique challenges as well. And so people who look any shades close to me, as I mentioned, are a rare find in our profession. And this can come with its own risk for emotional distress, isolation. And I actually attended a conference a few years ago in Wilmington, North Carolina, that was for women in healthcare leadership. And I heard a lecture on imposter syndrome. And it was at that lecture actually that I heard how impactful that syndrome is for underrepresented women in different spaces. I also saw a brief article abstract discussing how underrepresented female PA educators experience more burnout than their male counterparts, as another example. And then in addition to that, I was able to hear a webinar yesterday because I work from home, I'm remotely working, and so I'm able to listen to different podcasts and webinars throughout the day. And there was a collaboration yesterday between the American Foundation for Suicide Prevention and the National Alliance on Mental Illness, and it was called Community Health Equity Alliance. That was featured, that some people a part of that alliance group were on a panel, and it was brought to light as a reminder that only 1 in 3 adults of Black or African ancestry in the United States who needs mental health actually receives it.
Doing it all across the country.
So here is a slide that goes over how to recognize the risk factors. When I was thinking about this information to present tonight, I wanted to have you be able to see what the general population experiences, but then we kind of hone into focusing on our colleagues and us as clinicians. And so these are some risk factors that can extrapolate to the general population, but also I was thinking about how close we get to our colleagues when we're in confined spaces, working long hours. Many times they'll share, and we share with each other. We become closer sometimes to our colleagues, almost as close as we are to our family, if not more in certain regards. But if they have a history of a mental disorder or a family history, or they're experiencing a personal history of abuse, or if they have major events that affect their stability and supports, or some relationship stress. And situational stressors as well can be a risk factor. And when we think about situational stressors, sometimes we can be named in lawsuits, and that's a very stressful circumstance. We may have job changes. Many of our companies are undergoing reorganizations, and there have been layoffs in my recent work history, and different load changes that may have workload increases. Some of our colleagues experience a restriction of their license or professional isolation. All of those things can cause them to have these particular risk factors. Now, how do you recognize the warning signs? Because we know that sometimes it's easy to self-medicate and it's okay, and no one will say anything about it. Meaning that maybe you go to all the happy hours and have more than your usual one drink, and sort of place a band-aid over the problem by increasing your use of substances, but sometimes they can be substances that society accepts. You can also listen to language where your colleague might be expressing a lack of desire to live or a lack of purpose. They may exhibit signs of anxiety or agitation. You could see some sleep changes or expressions of feeling trapped or hopeless, or becoming more withdrawn and isolated, no longer wanting to socialize or take phone calls or do things that they used to enjoy. You can also see mood changes as a warning sign, and then again, the behavior of seeking access for lethal means. So the ultimate goal is to be able to weave these most important questions in your conversations when you're talking to someone that you suspect may be contemplating suicide. The literature says that it's best to kind of keep it natural. One resource recommended that you memorize a screener of some sort. It doesn't have to be this one, but a screener of some sort, so that you know automatically to kind of weave in the questions into your conversations, so that you can have some authenticity, but also create a non-judgmental space when you're asking those questions. So you want to know, have they wished that they were dead, or wish they could go to sleep and not wake up? Sometimes I will ask my patients, have you ever felt like you wanted that, like life wasn't worth you being a part of? That's how I'll phrase it sometimes. Have you actually had any thoughts about killing yourself, or ending your life? And then have you thought about how you might do this? This kind of gets to that question about plan formation. And then have you had any intention of acting on these thoughts of killing yourself, as opposed to if you have the thoughts, but you definitely would not act on them. Sometimes people will say that their faith prevents them from taking action, or they have other external factors that would prevent them from taking that next step. And then you want to find out, have they started working out details of how they will carry out this action, and do they actually intend to carry out that plan? And then the last question is, have you done anything, started to do anything, or prepared to do anything to end your life? Now, depending on the answers to these questions, you definitely want to get to the point where you can distinguish if you need to get immediate help by calling 911 or having them go to the emergency department, or if you need to call 988, the crisis line. And then, through my work in different counties, I'm made aware that some counties actually have a mobile crisis unit that you can call for mental health emergencies. And that questionnaire was created by the Columbia Lighthouse Project, and their message is just ask. You can save a life. And they have a printable card that you can download and print out and carry with you until you get those questions kind of down pat. And I like that they teach healthcare professionals that you don't have to be an expert in psychiatry to ask about the well-being of your colleague. And then, according to Harvard T.H. Chan School of Public Health, means matter. 1 in 4 people who had a near fatal suicide attempt acted within 5 minutes of making the decision. So almost 50% carried out suicide action within an hour of making that decision in their study. So, 5 minutes really can make a difference. You can reach out to your colleagues if you see them with some of those risk factors or signs and symptoms. Many times they're not acting the same way, and you can tell their behaviors are different, or they're not taking pride in their appearance like they used to. Whatever it is that you see, it does not hurt for you to ask, are they okay? And then create a space for them to share. And so I will put a plug in that I share. I reach out on my social media platforms. Many of you may see me posting on LinkedIn. I'm also on some other media platforms, but I know who's usually posting as well. And when they drop off and I'm following them and I don't see postings from them, I tend to reach out and see if I can offer support in any way and find out what's going on. And through me reaching out, I have found out that many people who look like they're doing great on the outside and for all appearances, they have lost a loved one, or they had to change jobs or move across the country, or even be caretakers of an elderly parent. And so they appreciate the extra touch. And I love this phrase, silence isolates, but connections heal. There's a lot of studies shown, and, publications that show how we need to be a little more transparent and authentic with each other. We need to let people know when we're hurting a little more frequently and when we need help. And as a culture of people of color, we're not so good at doing that. We tend to hold our problems really close and not open up and share with anyone unless we absolutely have to. Now, I'm going to shift into giving you some ways to address someone who's experiencing emotional distress. You want to show your support and let them feel that you care. You want to do some active listening and provide feedback to show that you're fully present. You want to encourage them to keep talking. If they're willing to share, you want to allow them space to share and to do so in an unhurried way. Many of us are trained with our motivational interviewing skills of asking open-ended questions, giving affirmation, reflecting back, and providing some summarization. You also want to find out about situational stressors. You want to get the details and find out how distressing are those situational stressors. And then directly ask if you suspect that the person is deeply distressed. You want to ask if they're contemplating suicide as an option. And if they do say yes, you don't want to freak out and make them uncomfortable with sharing additional information. You want to stay calm and then assess for risk and their immediate needs. So after you have conversationally assessed, now what do I do again? Remember, you are assessing for risk for lethal outcome. Is the person safe to stay at home based on what they've shared with you, or should they seek urgent care? And you do have multiple resources in most communities that you can use to try to get some help if the patient is amenable. And remember that I did mention that the studies show that most people decide to take that lethal action with just 5 minutes. And if someone can intervene in that time frame, it can save a life. And as we wrap up, I do have some provider self-care tips that I'd like to share, because many of us are giving all the time and we forget to pour back into ourselves. And so I love to highlight the importance of personal wellness investing. So during the pandemic, I had to become a telemedicine practitioner where I'm in a silo by myself most of the time. And I had to really get creative to fill my toolbox with things that keep me joyful and, excited about my days. And so remember to have grace for yourself. As we're seeing patients and encountering difficulties, remember that you're not expected to know everything, even though we often feel we do need to have all the answers. You don't. That's why we have resources. So call a colleague, do a little research or digging and tell that person who's asking something of you that you need to get back to them, and let the story evolve with time. And I encourage you to make time to enjoy your family and other important relationships. Don't put them off, instead of, and concentrate mostly on your work responsibilities. Try to continue to make space to enjoy your family and those other relationships. And also make space to have fun. Enjoy life. Go outside and play like you did when you were a child. Explore your hobbies. Have some creative endeavors, and try to keep your fitness regimen up as you are going about your days. And you'd also need to consider creating a safety plan for yourself. Sometimes we go through difficult times, and you do have those. I don't know who on the call can relate to having those days where you are so down in the dumps and so low and feeling like life is so difficult. In those moments, it is helpful to have a safety plan that you can review. Like, what are some things that you can do to take your mind off your problems? Who are 3 people you can call that will give you support? And then, if worst case scenario, you don't feel like you can do this by yourself, what are some numbers that you can call to get some additional professional help? And safety plans have been proven to reduce suicide risk. They are evidence-based and an effective thing to implement. So now I will stop talk. Well, I would plan to stop talking, but due to the format, I won't stop talking. I did have some space to talk, sip some tea and share, but since we are on time constraints, I'll just share that in order to encourage you to take better care of yourself, I'm going to be a little transparent and share that I have been in therapy off and on through difficult times in my professional career. Sometimes the expectations, and I felt like I wasn't quite meeting them, and that was mostly self-imposed, but performatively, you can really be hard on yourself. And so at times I've had to get therapy, and it has been very helpful. It has helped me to have above my computer screen, my 4 questions. Am I getting enough rest? Am I getting irritable? Am I getting forgetful? Am I making little mistakes? Because those are signs that I'm getting weary and I'm maybe pushing myself too far and I need to take some steps back. I have friends that I can call when I feel really, really bad and I need someone to show me my wins, because I'm not seeing them, and my mindset is very, very narrow. I have people that I can call that can help me, that I trust. And so I encourage you all on the call to have relationships that you can leverage in that way. And the reason I have this picture on here about sipping tea, I use this as my capstone project for getting my doctoral degree. But you guys saw that over 70% of PAs are women, and the PA Moms constituent group is the largest one in the American Academy of PAs. And so I think as minority clinicians, it's nice to pause and share what keeps you sane when work is not giving you sparkle and joy. So that was the activity we were going to do. And I encourage you to do that in your spaces when you have the time. One phrase that I heard yesterday during that collaborative webinar between the American Foundation for Suicide Prevention and the National Alliance on Mental Illness is that the stories stay and the lessons leave when we can sit with each other and share for a few minutes. And so here are some resources. I do rely on the websites, the American Foundation of Suicide Prevention. They are very, very research based, and the largest research-based nonprofit is what I understand. And then I participate in fundraising because I utilize the resources for the National Alliance on Mental Illness. But I came across an AAPA recommended source to address suicide called the National Action Alliance for Suicide Prevention. It is a little bit dated, but if you're bored and don't have anything to do at night, you can consider reading that. And then these other resources are available to you as well. But my last plug is, as a board member for NCCPA Health Foundation, I encourage you guys to consider applying for one of their grants so that you can raise awareness about some of the mental health challenges, or consider doing a project in your community that improves the health of those in your community. And these are my resources, and I thank you guys for the opportunity to share today.
Thank you so much, Dr. Lordeus. That was a very timely and relevant presentation, given especially this is Suicide Awareness Month. So we really do appreciate you taking the time to speak with us today. I will open the floor for any questions that anybody might have. We have a few minutes between presentations. If you'd like, you can also put your question in the chat, and then we can read those out for you if that's easier for you.
I will jump in. I'll let the participants know that you can enter your questions into the Q&A, and we'll be able to ask those for you. But in the meantime, I don't see anything in the Q&A right now, but I was wondering if you could share your experience, if you feel comfortable doing so, with just your connection with mental health and your family. You did speak to how culturally many groups are not open to seeking mental health care, right? Like it's frowned upon, or people feel as if you should be able to handle it at home, within your family, within your friends, and not seek outside help. And I was wondering if this is in your family, did you grow up with a connection with mental health, or did you kind of learn about it more in the future? Can you speak to that a little bit more?
Well, that's a wonderful question, Kimberly. So I thank you for asking it. I co-presented at the PA Moms Conference this year on cultural humility, that topic. But when I was doing the research for that, I did run across studies that show that if parents are open and engage in conversations about their mental well-being, so that their kids can hear them sharing, their stories, their struggles, how they're accessing help, it makes it a much more open environment for kids to share. And I stumbled into psychiatry, and I started seeing like the dynamics of different family struggles, and I didn't want my kids to feel afraid or uncomfortable to share. And so we have open time in our family where there's no repercussions. You can share whatever you want to share. If you don't like our parenting style, you can tell us during this moment and we'll talk about it. We don't have to do anything or move on it, but at least we'll be aware. But I think that having that openness in those conversations, definitely my psych experience plays into, feeding my family what I learned, but also not like freaking out as a parent when your child tells you something, and then pausing and being quiet and letting them continue to share, because teenagers might clam up if you react in a certain way. And so all of that has been beneficial, and I do practice what I preach in my household. And I didn't get a chance because I thought I was running out of time. So I didn't get a chance to talk because I really wanted to turn at the end of my presentation to make it more of a focus about us clinicians and how we're giving out but not pouring back in. But I meet so many of my colleagues of all different races that do not take advantage of the resources that their employer offers when they are struggling. And so, I'm of a mature woman's age, and my job offers some terrific resources like Maven. They have an EAP program. They have a Kaya program that does wellness coaching. Able to is another program that an employer might offer where you can have mental health coaching. And then I found out about this new resource called Conversations with the Chaplain. So maybe you don't want to access EAP, you don't want to do 10 sessions, but you're dealing with something that you just need to have a conversation with someone in a safe space. So I want everybody to try to think about utilizing their resources if they don't have people that they feel comfortable sharing what they're going through, because the employer is offering them, but so few are taking advantage of it.
I don't see any questions in Q&A, so I have another one. I don't want to take up all the time, but since I have the time,
Good.
could you I'm glad you brought up this last topic. Could you speak to the concern that some clinicians may have actually seeking help for their mental health? Because in a lot of times when we are becoming credentialed through hospital systems, they often will have a question on there that directly asks you, like, have you ever sought assistance for mental health or struggles with substance use disorder or anything along those lines? And I think I've heard clinicians say that there's just this concern that if they were to even seek assistance through these resources that are given to them through their employer, it may somehow affect their job. Could you just talk to that a little bit, and maybe help with some of those concerns that could be there?
Well, I did run across an article, and I'll admit that I was so focused on looking for this other point I was trying to find for my presentation that I didn't read it in detail. But it seemed as though I was reading that legislation had passed that healthcare workers could not be discriminated against, or have harassment at work based on the mental health resources that they seek out, or the divulging of some mental health struggles. So I can't say factually or quote the resource, but it is worth you looking at what your state laws are. But as far as the resources that I am very familiar with that I just mentioned, there's a confidentiality clause that your clinician will say at the beginning of because many of us are worried if we're accessing this and they work for the company and you're using their service, but they tell you at the beginning that all of this is confidential. Nothing will be shared with your department, with your employer. This is it'll be against HIPAA for me to divulge your medical information. And so before you get to the worst case scenario, you need to just access it. And I heard one therapist say, that sometimes you don't have to be in a crisis to access therapy. You just need to kind of see where your place is in the world and clarify some thoughts you might be having about certain things. And therapy can be so beneficial for a whole myriad of different reasons. And many times these resources are free. That's what I didn't understand when I heard how few of my colleagues are taking advantage of these things. They're often free. We see how mental health access is so limiting because of the cost, and the disparities for access is really, really great. And here many of us work for companies that offer these services for free. I think I see a question in the chat. Oh my gosh,
Yes.
Fred.
So
Oh no, that's Tiana, but it was okay, go ahead, Kimberly, what were you gonna say?
Oh no,
so
I
the,
wasn't going to say
the
anything. I think it's Kalita. Yeah, go ahead, Kalita. Sorry.
Oh, okay.
there's a question here that you mentioned from Tiana, and the question is, thanks for giving this wonderful talk. My question is whether you've dealt with imposter syndrome, and if so, how have you?
It made me laugh when I read the question out loud because, public speaking is a very, very big fear for most people. And, I push right through it. I realized that I actually have a quote on my desk that says, challenges make you discover things about yourself that you never really knew. And that's a quote by Cicely Tyson. And you hear other quotes that talk about how growth won't occur if you're always comfortable. Growth occurs when you're uncomfortable. So I definitely feel like I have imposter syndrome. I often don't feel like I'm doing as well as others may say I'm doing, but I'll kind of like be harder on myself or feel like I'm not able to do XYZ. But those thoughts are fleeting, like some of those other negative narratives we tell ourselves. Thankfully, mine, I can get rid of them pretty quickly. I have my degrees in front of me. I have like all these things around me that gives me affirmation and courage to keep moving forward. So for anybody who's listening, I encourage you to like confront it head on. If you need to get therapy in order to do that, then do that. But don't limit yourself and stay in that bubble of fear because you won't ever realize how great you truly can be. Was I able to answer? Well, she can't come up. Oh, Fritz said he'll be here for support. I don't know. That probably wasn't related to that question. That sounded appropriate though.
I think that was the last question that we had there. So again, I thank you, Dr. Lordeus, for presenting to us today. That was really very informative and it was a great presentation. So thank you again for your time.
You're very welcome.
Next, I'm excited to present to you. We have nurse practitioner Shaney Berthey. He'll be presenting on Brain on Fire. MP Berthey brings 6 years of ICU experience in cardiac, medical, and neurosurgery care, and now practices as an acute care nurse practitioner. She's deeply passionate about patient care and honored to present this unique topic to the VAMPA members and supporters. Please join me in welcoming MP Berthey.
Hi, everyone. I'm going to share my screen. I'm doing it right. Okay. Let's see. Can everyone see my screen? Okay. So I'm going to present the topic on brain on fire syndrome, also known as anti-NMDA receptor encephalitis. I am a newly graduated and recently certified nurse practitioner, acute care nurse practitioner as of September 7th, so very new. I had an experience with a patient who had anti-NMDA receptor encephalitis during my last semester of clinicals, which is where I met Shola. And it was so interesting to me. And I was talking with my preceptor, Megan, about it, and she was talking about how rare this was. And I hadn't really heard, too much about it. So I decided to do a PowerPoint on it that I'm excited to present to you guys. So we're going to start off with what is anti-NMDA receptor encephalitis. It was actually officially discovered in 2007 by Dr. Dalmo. He observed a set of symptoms in a group of 12 young women and started to do some research on it, and that's when he coined the term anti-NMDA receptor encephalitis. It was originally thought of as only a perineoplastic syndrome, which part of it is, but the umbrella of it is an autoimmune encephalitis that is B-cell mediated. The autoantibodies attached to the NMDA receptors in the CNS, particularly on the NR1 subunit, which has to do with glutamate, which I'll talk a little bit about as we go further in the presentation. It is an acute to subacute form of encephalitis, which is very important in the diagnosis and suspicion board as well. For the role of the NMDA receptor, it has a few roles. It's very crucial part of the CNS system. It has a role in memory formation, synaptic plasticity, which has to do with the adaptation of the brain and the receptors, cognition and balance of excitatory neurons. There is a strong relationship between NMDA receptor the NMDA receptor, glutamate, and dopamine. The NMDA receptor and glutamate, when glutamate attaches to the receptor, it can actually control the dopamine release and kind of keeps the dopamine at bay. I was reading a couple of papers about it, and it kind of referred to the NMDA receptor and the glutamate as the brake of the dopamine, as in like the car, and the NMDA receptor is the steering wheel. So that is very important as we move forward as far as the signs and symptoms of this form of encephalitis. For the epidemiology, it is the most common form of autoimmune encephalitis. However, it is still very rare. 1 out of every 1.5 million people per year are diagnosed with it. It affects anyone, well, age range for all the way from 2 months to 85 years old. Females are 4 times more likely to be affected, and I was reading a study that actually reported of total cases, up to 93% of those were female. And the most common group in general is 25 to 35-year-old females. For the triggers, there's quite a few. Ovarian teratoma is the number one, which kind of explains why females are more likely to be affected by this type of encephalitis. Another trigger is viral infections, specifically post-infectious HSV. So it can be from 3 weeks until forever, where the HSV infection is latent, and then when a stressor occurs, and some people have the cold sore. I'll talk about this later in the presentation, but that can kind of spread up to the brain and the neurons in the brain during those relapse periods. Other cancers are also a trigger, although they are less rare than the ovarian teratoma. Those are testicular, lung, and breast cancer. Even more rare is bacterial infections that can be triggers. However, over 50% of patients, the trigger is unknown. For the pathophysiology in cases related to the teratoma, so teratomas can sometimes have neuronal tissue, including the NMDA receptor. If you get a viral infection, your immune system is in overdrive. It's trying to fight this viral infection. And sometimes the virus can have molecular mimicry for the NMDA receptor. They kind of look alike to the body. So the immune system recognizes and targets the NMDA receptors, and the IgG autoantibodies, they bind to that NMDA receptor, and it causes internalization of the receptor. So the receptor will actually go back into the membrane, and it causes a disruption of the neurotransmitter balance, which I kind of touched on earlier with the increase in dopamine. For the pathophysiology related to the reactivation of the HSV infection, as mentioned previously, if there's a cold sore, it can kind of travel along the nerves back into the brain. And kind of the same process with the teratoma, there's this molecular mimicry where the immune system will mistake the HSV and mistake it for the NMDA receptor. Another thing that can happen related to the HSV is there can actually be damage to the neurons that expose the NMDA receptor and make it more readily available for the immune system to attach to the receptor. And same thing with the teratoma pathophysiology, the autoantibodies bind to the receptor and causes the internalization of them. The diagnostic criteria for probable anti-NMDA receptor encephalitis. So I was actually listening to this podcast, and it was talking about how it was by Dr. Anderson, who's in one of my references, and he was speaking about how and it's very tricky to diagnose and for NMDA receptor encephalitis to be on your radar when patients present. So in 2016, they actually came up with a set of probable anti-NMDA receptor encephalitis criteria, so that way when somebody presents to you, it can kind of be on your radar for you to move forward with some testing. So as mentioned previously, it is an acute to subacute, so it'll be less than 3 months of onset. And that is very important because Dr. Anderson talks about how sometimes he sees people in the clinic and they say that they have been dealing with psychiatric dysfunction for 6 months or a year or 2 years, and that should automatically remove them from the suspicion of this form of encephalitis. So you would want to have 4 of the 6 symptoms for it to be probable, and those are psychiatric, behavioral, or cognitive dysfunction, speech dysfunction, seizures, movement disorders, autonomic dysfunction, and central hypoventilation. If those are present, you can get an EEG and you can see slowing, epileptic changes, or delta brush changes. For CSF abnormalities, so a lot of these, or all of these patients would get an LP, and you could see an increase in white blood cells, oligoclonal bands, which are just IgG antibodies in the CSF, and elevated protein can be present as well. And most importantly, an exclusion of other differential diagnoses. So those were for probable, and then for definite diagnosis, 1 or more of the 6 symptoms that I just mentioned on top of a positive NMDAR antibody. The other differential diagnoses are other forms of encephalitis, psychiatric disorders, and as mentioned, that's one of the important reasons why this form of encephalitis will be acute to subacute. Neuroleptic malignant syndrome, that can happen from antipsychotics, which can actually make diagnosing even more complicated, because if you're unfamiliar with this form of encephalitis and a patient comes in displaying the psychiatric symptoms I'm going to talk about, the first thing that we do is to treat them with antipsychotics, and that can actually turn into neuroleptic malignant syndrome, and that can even make it even harder to diagnose and differentiate between the two. Catatonia, exposure to drugs and toxins, specifically ketamine and PCP, as those interfere with the NMDA receptor as well. And another differential diagnosis is withdrawal of substances that are used by the patient. The presentation happens in phases. There are 5 distinct phases. However, patients may present in different stages and actually have different stages at different times, which makes it a little bit harder to diagnose as well. The prodromal phase, 40 to 60% of patients will have this phase. It mimics viral infections. They can have symptoms such as headache, fever, nausea, vomiting, and upper respiratory symptoms. When Megan and I had this patient when I was in clinicals, his wife had actually said that he had been battling this upper respiratory infection for about a week or 2. And then he presented to the ED with the psychotic phase. So it usually starts within 2 weeks to less than 3 months from the prodromal phase. It is rapidly progressive. The manifestations include hallucinations, so seeing things, hearing things that aren't there, acute schizoaffective episodes like disorganized thinking, unusual behavior, depression, mania, seizures that sometimes throughout the phases can progress to status epilepticus, which is when some patients will actually go to the ICU for that. That's one of the reasons why these patients with this form of encephalitis come to the ICU. And agitation. Again, with that patient that Megan and I had, he was having such extreme agitation. In one night, he had 7 security alerts called on him. It took like 6 security officers to hold him down. He had assaulted multiple family members, multiple staff, all while not being there mentally. He had no idea what was going on. And to support this phase, you would want to give antipsychotics and anti-epileptic drugs for the seizures. The next phase they go into is the unresponsive phase. The manifestations of this phase is mutism, decreased motor activity, and catatonia. You can support the catatonia by giving benzodiazepines, as that helps to regulate the NMDA receptor pathway. And actually, studies have been shown that electroconvulsive therapy has been beneficial in this phase. For the next phase, it is the hyperkinetic phase. There's two phases of it, or there's two parts of it. One is movement disorder. They can have dyskinesia, involuntary repetitive movements. The most common one is orolingual, which is lip smacking and tongue protrusion. Dystonia, which is muscle contractions. And this phase is very challenging to control. A lot of times they give high-dose sedatives, but also botulinum and tetrabenazine have been shown to be helpful as well. The patient that Megan and I had, he was having these muscle contractions in the bed, and it almost looked like he was levitating off the bed because of how severe these muscle contractions were. The next part of the hyperkinetic phase is the autonomic disruption. These manifestations are labile blood pressure, labile heart rate, arrhythmias, temperature disturbances, and hypoventilation. A lot of these patients, over half of them get to this point and end up needing ICU management, which the patient that Megan and I had, we ended up having to send him to the ICU. And then the last phase is the recovery phase. So unfortunately, the recovery phase is an incredibly long process. The most significant recovery happens within the first 6 months. However, more often than not, the patients are looking at a recovery that takes years. I was reading some studies that say even up to 3 years for the total recovery time. And unfortunately, some patients may have residual deficits as they recover from this encephalitis. For laboratory testing, so when you have a patient that comes in and you suspect that they may have this form of encephalitis, routine labs are usually unhelpful and unrevealing. With the lumbar puncture, you're going to test for the HSV in the CSF just to differentiate the cause. And in the lumbar puncture, there will be anti-NMDA IgG antibodies. For these antibodies, they are present in the serum and CSF. However, they are significantly higher in the CSF. So I was reading some resources that said to test the CSF even if the serum is negative. And unfortunately, there have been some false positives that have been reported in the serum. I was reading one study that said up to 30% in the serum can be false positives. So they really recommend getting the CSF and the serum. For scans, a lot of these patients get an MRI, and they are normal in most cases, ironically. When they do have abnormalities, it is non-specific white and gray matter hyperintensity that is most often in the temporal lobes, and cerebellar atrophy, which is due to the receptors being hypofunctioning. For the EEG, as I mentioned earlier, there's going to be some generalized slowing that is also related to the hypofunction of the receptors. Subclinical seizures can be present, non-convulsive status epilepticus, and you really want to get an EEG as these can rule out primary psychiatric disorders. And in the cases of anti-NMDA receptor encephalitis, the EEGs will be abnormal in up to 84% of cases. For other imaging, you must do a whole body imaging to detect for tumors. The whole body scan is very important. You don't want to do just the brain or just the chest. And transvaginal ultrasounds is most critical for young women. However, I was reading some studies that said transvaginal ultrasounds can miss very small teratomas and that a pelvic MRI would be more beneficial. if you really suspect that they have this form of encephalitis. For mortality and morbidity, there are some independent predictors of worse outcomes. They are ICU admission, treatment delay, which is why it's very important to spread this education and to make providers aware of this form of encephalitis. No improvement after 4 weeks. So I'm going to talk about it later in the presentation, but 4 weeks is kind of the gold standard for the first line management, and then you would move on to the second line. But if there's no improvement after 4 weeks of the first line treatment, it is a predictor of worse outcomes. MRI abnormalities, as most of them are normal, when you do have them present, it is an indicator of a worse outcome. And white blood cells greater than 20. 25% do not have a meaningful recovery, and about 5 to 10% are deceased within a year of diagnosis. And then there is a 10 to 30% chance of relapse in getting the anti-NMDA receptor encephalitis again. For treatment, there are currently no FDA-approved treatments. As this autoimmune disease is so rare, there is such limited research and even more limited medications that have been tested. First and second line treatments that are used off-label. For the first line management, the treatment may start before the final diagnosis. So a lot of times these CSF cultures that we send off usually take a couple of weeks to come back. So you want to start them on treatment as soon as you suspect that they do have this form of encephalitis. Corticosteroids are the #1 mainstay starting treatment, and you would want to give IV methylprednisone. Also, IVIG and Plex or plasma exchange. I was speaking with one of the neurointensivists that I work with, and we were talking about this, and you would actually want to use either IVIG or Plex to start. And then if you don't see any improvement with one of them, then you still have the other one to fall back on. Most importantly, if they do have a teratoma or another tumor, that is priority to get that resected, as that is the trigger for this encephalitis. If the patient is, you want to start them on IV acyclovir for the HSV infection. And then, as I kind of touched on, there's a controversial order of which IVIG, Plex, which one you start first. But most studies I read said that Plex before IVIG to clear out the autoantibodies in the system. Fortunately, second-line therapy is often needed for these patients. The second-line management, as mentioned, used if no improvement is seen in the first 4 weeks of therapy. Rituximab, cyclophosphamide, azathioprine, and mycophenolate mofetil. All of these are second-line management and can be used to help with these symptoms as well. For complications, as I mentioned, relapse, demyelinating disorders such as neuromyelitis optica spectrum disorder, where patients will lose their vision. The connection between anti-NMDA receptor encephalitis and demyelinating disorders are unexplained, but this can be a complication. Neuromalignant syndrome, complications from prolonged hospital stays, such as hospital-acquired infections, ventilator-associated pneumonia, pressure injuries. Those are all things that can be a complication for this encephalitis. And then persistent cognitive deficits, post-recovery. These are more specifically in memory and language. For preventing recurrence, you want to do frequent scanning, especially in those where you don't find a tumor or you don't find a teratoma. They actually recommended scanning every 6 months for up to 4 years, just because the correlation between anti-NMDA receptor encephalitis and teratomas and other cancers is so high. You want to do a regular follow-up. As I mentioned, 10 to 30% of these patients do have a relapse. Long-term immunosuppression may be needed. And there were actually a few studies that said that rituximab, which is one of the second-line treatment, decreases the risk of relapse. So they are doing some studies on starting that earlier versus starting that later. But unfortunately, with how rare it is, it's very hard to get adequate data. For supportive care, family support is very important. These patients are looking at a very long road ahead of them, sometimes years. So it's very important for us to inform family that that is the outlook. And most of these patients actually, once they get past the recovery stage, about 75% of them actually have very good outcomes. So it can be reassuring to let families know that even though this is a very long process, there is a great chance of meaningful recovery. Patient support, of course, especially as they progress to more of the recovery phase where they're, starting to get their mentation back. It can be very alarming to them of everything that they've gone through. And I was reading a pilot done by Dr. Anderson, and he had listed these two resources for family and for patients, Autoimmune Encephalitis Alliance and Encephalitis International. And I kind of dug into their websites, and they had really good information that was very easy to digest for family members and for patients. Challenges in diagnosis and treatment, as I've mentioned a ton, it is very rare. It's often mistaken for other disease processes and or drug-related reactions. And the longer that it goes undiagnosed, it is a treatable encephalitis. So the longer it goes undiagnosed is a less chance of a meaningful recovery. As I mentioned, can prevent in different phases, which makes it difficult to diagnose. It's not a one-size-fits-all for all patients. Not every patient is alike. Only 50% respond to first-line management. And then there is limited research on outcomes from recovery and on. For the role of the care team, there's going to be a lot of different types of physicians involved, different types of groups involved. For neurology, they're often needed for the diagnosis. Psychiatry, they have the neuropsychiatric symptoms, so you want to consult them as well. Sometimes infectious disease can be consulted, especially in cases of viral or bacterial infections. An intensivist is sometimes needed if the patients present to the ICU. And then pharmacy for education on medications that are not often used. I know as a nurse, I don't think I have given any of those second-line medications. So it would be very helpful for the pharmacist to educate nursing and the providers on the side effects of these medications and what to look out for these medications. Improvements to be made. There's currently no FDA-approved medications, as I mentioned. Such a rare disease case studies are limited. I was reading that there have been actually no randomized controlled trials. Focus on increasing education as early diagnosis and treatment are key. During my clinicals, fortunately, I was with Megan, who has seen this before. But I know I'm just a newly graduated nurse practitioner, but if I was to see that patient, I would have no idea what's going on. And I'm sure, a lot of new providers might feel that same way. And basically the first day we met him, Megan said, I think he has anti-NMDA receptor encephalitis. So I think increasing education and making people more aware of how this form of encephalitis presents can be very beneficial, because a lot of times people come in and they are having these psychiatric symptoms and people automatically assume that it's a psychiatric only episode. And once you kind of get your blinders on, if you see that and you're like, oh, that's just a psychiatric patient, and you kind of put your blinders on and don't look at a bigger picture. And I know they say think horses, not zebras, but if you do have education on this form of encephalitis, I think that it would be beneficial to have that in the back of your mind if somebody presents with psychiatric symptoms, especially if they're acute to subacute presentation. For recent advances in treatment, I was actually looking up clinical trials. I provided this slide only because I wanted to demonstrate how long the process actually is to get a drug developed and put out on the market. These next three medications that I'm going to talk about that are in clinical or are in the phase of development are in 2 to 3 phase. For ART 5803, it is currently in phase 2A. The start date was August of this year for this phase, and the completion date is going to be December of 2026, and then we'll move to stage 2B. The way this medication works, it binds to the receptor without affecting it, and it blocks the NMDA receptor autoantibodies, so the receptor cannot go into internalize into the cell, and it reverses signs and symptoms of this form of encephalitis. And this phase is focusing on safety, efficacy, and ability for the patient to tolerate it. The Cielo trial is in phase 3. It is a randomized double-blind medication study, and it targets the IL-6 that's responsible for the inflammation, which is a main part of encephalitis. There's a lot of inflammation that happens, so that would help decrease signs and symptoms as well. That was started in September of 2022, and the phase 3 is set to complete in December of next year. The Extinguish trial, which I found very ironic for the brain on fire in the Extinguish trial. It is in phase 2B. It is a randomized double-blind, and it is a monoclonal antibody. The start date for this phase was March of 2022, and it is set to complete all the way in September 2028. So there have been, or there are kind of pushes to help anti-NMDA receptor encephalitis, especially because it is, treatable, and if caught early and with these medications that may help, it may decrease the recovery time. When you think about even 6 months of recovery time is a lot of recovery time, given that they go through so many phases, and these phases are so severe, like the psychotic phase and the hyperkinetic phases. Those are such severe phases, and they go through all of that, and then the recovery time on top of that is 6 months to up to 3 years. So I was very excited to read that there are some clinical trials for medications to help. The clinical pearls that I will almost end with, chance favors the prepared mind. Dr. Anderson has that in his one of his papers, and he was just talking about being educated on this form of encephalitis, and it is such a rare chance that you will encounter this form of encephalitis because it is rare, but early diagnosis is key. In his paper, he mentions to be on high alert with subacute onset of behavior changes, especially in individuals with no drug history and no previous psychiatric history. He actually said that when patients present to the clinic and he suspects that they are starting to have this form of encephalitis, he said that the key phrase that he hears all the time is patients saying, "I feel like I'm losing my mind." And he kind of differentiated that between psychiatric disorders that cause such severe signs and symptoms, like the agitation and the hallucinations. They won't feel like they're losing their mind. They almost don't realize that their mind is lost. So when patients come in and they're, feeling like it is just such an acute change, to be on high alert for this form of encephalitis. Early recognition and prompt treatment is critical. And then he mentions to extensively search for ovarian teratoma, and if not found, search again. Care team involvement is crucial, especially with neurology and psychiatry. They kind of go hand in hand with treating these signs and symptoms and putting these patients on the correct medications in order to speed up the process of their recovery. And then recovery takes time. And then any questions? And I put my email down at the bottom if anybody wants the references or has any further questions. And then those are all my references. That's it.
Thank you so much, MP Penberthy, for that very insightful presentation. At this time, we'll open the floor for the panel discussion and any questions from the audience. If you need to type, just place it right in the Q&A and we can read that back to her.
I don't see any questions in the Q&A, but I have a question to kind
Yeah.
of kick it off here. So when you said when this patient came in, when you were on your clinical, the nurse that you were working with kind of just had a feeling that this patient had this
It
condition. Is that
it
right?
was
Or kind
it,
of how did
it
it
was
unfold?
the nurse practitioner that I was doing clinicals
Mm-hmm.
with. She
Yeah.
had said that she saw this was only her second time in 6 years seeing a patient with this. But she said that these symptoms are just so out of character. The only way I can describe it, and I actually should have mentioned this, um, going over this research, it kind of made me realize this was discovered, coined the term only in 2007. And when you
Mm-hmm.
think about like previously in history, you know, people talk about like exorcisms and people having psychotic breaks randomly and getting put into, psychiatric facilities. And it kind of made me wonder how many of those, it mostly affects women, how many of those women were coined to just be crazy and they actually had a teratoma. So she had seen it kind of looked like he was truly, it looked like he was possessed because he was so straight and like leaning up in bed and saying these random phrases and throwing things at people. It was very terrifying to watch. And I think just having that, I've never seen a patient like that before. So I can only imagine that when Megan saw it, she was like, I recognize this.
And was it with this patient that you guys have with the nurse with your fellow nurse practitioner? What did he not have any known like psychiatric history? Was it kind of that case, or did he have, or did you really even know? I guess because of how you presented, you may not have even known that.
So, from the information that we could gather from the notes and from the wife, she said that he was in perfect normal health. They had just been living their normal life. They had kids, he had a job, and then he had this, they thought viral infection. And then he actually became altered. They took him to the ED. His routine lab work came back normal, so they just sent him home. And then he presented in even more of the psychotic phase. And that's when Megan kind of thought that that's what he would have.
I see. Okay, very good. Thank you.
Yeah.
I have another follow-up question since everybody's so
Okay.
quiet. Um, did you ever watch the movie or read the book Brain on Fire related to the condition after
I
like
have
reading about
watched,
this and learning about it? Uh-oh. Did she freeze for you
Thinker.
too? Oh, there we go. I think you're
um,
back. All right, there we go.
Um, I saw the Brain on Fire on Netflix. I hadn't watched the movie. I just saw that it was, playing on Netflix, and I kind of skipped past it. But then ironically, like timing perfect, we had this patient. And so I watched it, and it was, that's when I started to think about how many people that has happened to, or how many people that still happens to, because this is so rare, and a lot of people, a lot of providers don't know about it. How often do they just send them to a psychiatric facility? And unfortunately, the delay in treatment delays the recovery time. So they'll probably, be there for a very long time.
All right, thank you.
Yeah.
Thank you, Shaney. This is a very important topic. I feel like this topic is something that, as you mentioned, a lot of people are probably misdiagnosed for psychiatric illnesses and other illnesses. What do you think we can all get from your lecture today that will make us think, okay, we have to think about this condition and advocate for patients?
I think the main thing to take away, and the main thing that I took away, is the time frame of how these patients present. Um, these patients, it's like a switch hits, and they're having this major psychotic episode, where and a lot of these patients don't have psychiatric history and don't have a drug abuse history. So I think that should signal, that this could be this form of encephalitis, because these, schizophrenia matches some of those symptoms, the hallucinations, the kind of the delusions and the the way that they think. And I think it does often get misdiagnosed, and I think we should really focus on the specific time frame of it being acute to subacute in patients who were completely living their normal life before this. And if they're women, that as well.
Thank you.
Yeah.
Okay. I don't see any other questions in the Q&A. So as we come to the close of tonight's webinar, I want to thank Dr. Lordeus and NP Berthey for their thoughts and presentations. I also want to thank you all for taking the time out to join us this evening. This is just day one of our fall webinar, so if you are available, please join us tomorrow night for our student-led webinar. And keep an eye out for additional upcoming events from the Virginia Association of Minority PAs, and continue to engage with us as we advance education, advocacy, and community support together. Thank you again, everyone, and have a good night.
Thanks, everyone.
Thank you.